Board meeting today, 29th of July. We have finished the annual general meeting, which started an hour ago. We're now on to our normal, thank you, Emma, standard monthly board meeting, which begins as usual with a reminder from me, if anybody's listening online, if they'd care to complete an evaluation form, that would be really helpful. We have some apologies. On the non-executive side, Louisa Dillman and Sue Hunt aren't able to be here today. On the executive side, Kat Noble and Chris Morgan. I haven't had any declarations of interest. Anyone's welcome to make one now? No? Okay, so let's go straight to the minutes of the last meeting. Can I please begin? Oh, Steve.
Sorry, minutes.
Minutes, yes. Begin with matters of accuracy. Steve.
I was there.
You were there? Excellent.
Yes.
Terrible omission.
Apologies.
Sorry about that. Any other matters, important matters of accuracy?
Well, not as important as that.
Okay. I don't think we have anything in the minutes then that isn't picked up either on the action log or in the main agenda. So we're working on the performance report.
Yeah, and it's on the agenda.
Yes.
Yeah.
Okay, fine. Anything else, Nick, on the that you want to talk about on the
Rising, no?
No, that's rising.
Close.
Action list. Okay, fine. All right. So, first section of the agenda, as usual, is on performance. Begins with your chief executive report, Nick.
Okay. So I'll just quickly whip through each of the items, pausing for questions on each. The 0845 service has continued, in fact, latterly with the hot weather and the continued advertising of 0845 to the public to phone in the event of heatwave advice being required, which is a little outdated now. We've seen volumes going up to near 28% of historic volumes, but I think that will subside, assuming that the weather does so also. But more importantly, we are in discussion with NHS England and anticipate that we will reach agreement to extend to November the provision of the service, but that it is likely to end in November. That is our working assumption currently. So I don't know if there are any questions on that. Nope. Okay. I'm not sure that I need to give any further update on 111 as I've just done so in the annual general meeting, so I'm just going to skip lightly over that if that's okay.
Yeah.
That's right. Okay. Care Connect is due to launch in the next day or so, employing about 95 staff, I think, Ruth, I'm going to ask you to correct the site it's based at, which I think is not, or please confirm, Nottingham, Newcastle, Bristol and Wakefield, with Milton Keynes as a backup site if needed. So apologies for that slight correction. And I think NHS England are, on this occasion, pleased with what we've done. Is there anything further you wanted to add to that, Ruth or Alan?
No, just to say it's starting with Acute Trust 17 across London and the North East, going live this week, where the public will be able to provide feedback via telephone, online or text.
What happens to that feedback, Ruth?
That feedback is logged and then sent directly to the trust to respond to.
Okay, and does the loop close with us? Do we find out what?
We only get involved with following up with the trust if we have concerns that there may be symptomatic problems as part of that feedback. Or
symptomatic meaning a patient with some symptoms?
Yes. So if there is feedback which is a mixture of feedback, but there may be symptomatic concerns coming through as part of that feedback, or if the feedback is of a particularly urgent nature in terms of it needing to be dealt with, we will follow it up with the trust directly, immediately.
Okay. Tim?
Whose responsibility is it to close out the issue? Because this is like a customer complaint, isn't it? Is it the trust's responsibility to close it out and
Yes.
go back?
Yes.
Okay. And there's a procedure for that.
Yeah.
So what What happens if we've got? So we'll be notified that they're closed.
Yes.
Okay, so.
There is a feedback loop to us that
Yes.
they've closed the issue.
So we're using the same system, so it will be clear when the feedback has been closed.
And then if
the member of the public has the right of reply to say,
sure, the customer is
yes,
accepted that it has been closed out. And what do we do if it's not closed out? Do we have any responsibility?
I think it's very similar to TripAdvisor methodology, which so the person who's visiting, as it were, or experiencing the service puts their comments onto TripAdvisor, and I think that most owners and runners of hotel establishments look very keenly at their TripAdvisor feedback and respond to the individual comments that have been put on there. And it's the trust's responsibility. In the first place, they've invited the feedback, so they've got posters all around their hospital site saying, please help us to make things better for our patients, give us feedback. So the responsibility rests with them. We are simply a link in the chain to help patients log their feedback, not responsible for providing them with the answers.
Thank you. I'm
And
reassured.
are we doing any analytics on it? So we're not responsible for looking at trends or providing an overview of what's been.
we're responsible for the analytics for the part of the service that we cover, but that's a subset of a much bigger analytical piece, which is being managed by NHS England.
So in amongst the rather grim news about 111, it's good to have that service starting, and similarly also now to be able to formally report that we've signed the contract for the provision of the health and symptom checkers and associated consultancy services with the Australian call centre network called Health Direct.
Steve?
Yeah, so how lucrative is that to us?
The actual contractual amounts escape me directly, but it's something of
Six-figure sum.
yeah, and I'm not sure that I would mention it in the public domain, but it's of the order of
Okay.
6 figures.
So we
What-
use. Sorry.
can-
So will we use that to further develop the service then? Is that going to be?
Yes.
And what responsibilities have we taken on long term for maintaining, updating?
So we've taken on responsibility for continuing to provide updates to the existing content, but some of that content is Australianised, if that's the right description, which the Australians themselves take on responsibility for.
But in relation to updating the core content, what's the extent of our commitment over what period of time?
So this is a 2-year contract.
Alan, do you want to?
The initial
Sorry,
contract period is for 1 year.
1 year.
Yeah.
Yeah.
So we have no ongoing commitments beyond that year.
This isn't an
Correct.
in perpetuity
Correct.
arrangement.
And,
Thank you.
and,
That's
and
very exciting.
it is one way. It's us providing updates. So if we're responding to NICE guidelines,
Yeah.
for example, in our content, then we inform HDA that would potentially apply to them in addition, and it would then be up to their clinicians to fold that into their health and symptom checkers as they see fit.
Great, it's fantastic.
Very good. Yeah, I think it's
Nice
excellent.
model, well done.
Yeah, well
Thank
done.
you. That's the end of my report.
Anything else? Any other questions for Nick? Okay. Let's move on then to the performance package, which
Yeah.
Jackie will guide us through.
Okay, so if I just take us through the corporate scorecard first of all. You'll note that at this time we've now got all of the detailed appendices accompanying the scorecard, with the exception of the one for other services, which will be available next month because that's still being developed. I just need to make one correction on the scorecard itself, the header sheet. Under quality and account and outcome performance, it should read actions arising from complaint action plan rather than complaints actions within deadline. But the narrative is correct on the scorecard itself, but it wasn't correct on the print sheet. So I just need to point that out. In terms of the overall scorecard, if I just concentrate on the red areas for now and then see if there are any issues. So the first one is percentage of staff compliant in safeguarding training. I think Tricia may wish to comment on that particular one. We do think it is going to go higher once we've cleansed some of the data, because some of it may relate to staff who've now left.
Yeah, that's correct. It's steadily increasing. We've had to do a data cleansing of staff that have left the organisation, and some staff were actually compliant with the records we were showing they were doing. So it's steadily increasing.
Okay. So the next one is the actions arising from complaint action plans, which again that is still very low, and again there's some sort of data cleansing required.
There's some data cleansing, and there is a focused attention throughout the clinical governance and the operations team drawing attention to make sure that improves.
Presumably, just thinking about that in particular, I'll come to Steve in a minute. I mean, we've launched on a large scale new services. It's not unexpected that we'd end up with a bit of a backlog on, very large amounts of feedback.
Yeah.
So, I mean, how worried are you about it, Tricia?
There is a risk assessment done on each and every health professional feedback and complaint. It's investigated, and then the actions arising out of it. So this is the actions. So the issue has been investigated.
Yeah.
Actions have been identified, and then this is closing the loop to say, have all of those actions been implemented and completed and signed off? And it's connected to some of the team managers having left the organisation, some of the employees having left the organisation, and actually just not the closing down a bit within our systems and processes.
Okay, so what's important? So I understand the sort of reasons that may give rise to this backlog. The question is, when you do those investigations, are the highest priority actions now? So the 51% that have been done, are you able to say to us you're confident that the important ones with significant implications are actioned immediately?
Yes.
Okay, so we're looking at a tail of less significant changes that haven't been closed out?
Correct.
Okay, perhaps we could minute that.
Is that so? I mean, can I just ask a question?
Yeah.
Is that something, therefore, that will be resolved in the reasoning? I didn't know if you had a timescale on it, but in the near future. Otherwise, I was thinking it's something our internal auditors could help with this if there is something worrying you, but it didn't sound as though there was something worrying you, that this would resolve within a matter of a reasonable timescale, should we say.
We have the clinical governance team are focused on this. We've been driving improvements on the core review and statutory and mandatory and this particular target. I think we will have made significant improvements by September, and I'll report at September.
So we can have a look at it.
Yeah.
Then. Okay, thanks for that.
Okay, thank you. Steve, you were in the
Thank you. I've got two comments. Well, one is a question, really. The first is about rostering efficiency. That's not red, it's amber, 85%. What I find difficult in reading this is how it's getting some sense of how we've progressed. So what I'm not clear about is that 85% better this month or worse this month. So that's just a comment and a question.
Yeah. So perhaps it would be helpful if we used to have arrows, didn't we?
Yeah.
So
I think if you look on page 9 of 10, Steve, in the more detailed pack, it gives you the graph, gives you the trend on that particular one.
But I don't want to have to refer back to a little arrow.
Oh, okay. Yeah, right.
Quite helpful. And the other comment is
the arrows back. Yep, understood.
Given the stress amongst the organisation at the moment, I just think the 6 leave figures are a lot better than I would expect them to be. So I'd like to comment on that.
Roger, would you like to?
Yes, I mean we are almost. I mean if you in another report the 13.2 is actually rounded down and we become green, so we're very close to our target on that, and that does bring us well within the sort of remit of NHS Trust, which is quite something given where we've been when the organisation was more stable than it is at the moment.
Well done.
Yeah. Thanks.
Very good. Jackie, is there anything else you wanted to talk to us about?
The other report that I would quite like to mention is that we've got within your pack, it looks like that, the 111 national overview. which I think we did have in April, and we haven't had since. This is a report that we get nationally. It's only reflecting 1 week. It's a week ending 26th of June. And that's because the information comes to us as percentages, so we can't amalgamate a month's worth of data. We also don't get details of exactly what's included in some of the data, so not absolutely clear what's included in the callback rate column, for example, and in the triaged columns, you might wonder why we have 137% of calls being triaged, and that is because within Cumbria and Lancashire there are a number of calls that are dealt with by North West Ambulance Service, but if they need to be triaged by a nurse, they come back to us. So that's why we don't answer the calls, so it's not in our call volumes, but we do get the nurse.
Could you just remind us of the definition of triaged calls?
Well, again, we don't know exactly what they've included in here.
How do we interpret triage calls for our services?
Well, we would have two, wouldn't we? We would have all calls would be triaged, but we'd also have some calls which would be triaged by a nurse. I can only assume, because they've got over 100%, that these must be relating to the calls triaged by a nurse.
I'd assume
But we
that
don't
the
know.
triage calls is basically a call for which a record is created and they start the assessment process, and the difference between that is people will drop out before they get to that stage.
I mean, this seems to be a remarkable range from triage calls being from below 70% to over 100. That looks like a very old measure.
Can I suggest that we liaise with NHS England's stats team and try and provide the board with a slightly more precise definition of what this means?
It just
try and get that.
Just seemed incomprehensible to me. Right, good, thank you.
On this chart, I found it quite useful actually, because is it just 1 week? Is it week ending? It's 1 week's calls.
It's 1 week's calls, and they only give you percentages, so you don't have any idea of volumes.
So it's
You
not
don't have any.
Idea of
Idea of
volumes.
volumes. It's just all percentages.
It's not years to date.
No.
Because there are areas where, like our callback rate looks very low, and the others look higher. It's difficult, isn't it? It looks like there's some interesting conclusions that you could draw from this, but because of the uncertainties of how it's been done and the percentages, it's difficult to do.
I think the overwhelming conclusion that I draw from this is that our access is good, and on all the other measures we are in the pack.
Yeah,
that's good.
Yeah, actually.
Well,
I don't know, but
it's slightly difficult to say. I think we can be confident about our access measures. It's difficult to know what some of these others mean, and without one of the important measures that's not on there is the proportion of contracted calls that we're dealing with, and that's it's a fundamental. You can't make sense of this without understanding that.
Yeah.
So I think interesting. Slightly difficult to know what conclusions to draw.
Would you like this report each month?
Yeah, I think so. I think if you can bear with us asking random questions about which we undoubtedly will, and if you can particularly help us with what the triage calls means, which is a bit opaque.
So the only other one which I think is worth mentioning is the staff receiving 3 or more call reviews in the previous month. We didn't have the data available at the time of printing the papers for 111. And I think Tricia, you were going to give an update on those.
We have made significant improvements in our core review, and we are over 95% of all staff having 3 core reviews, and that's due to some incredible work undertaken by John Sunderland and Stuart Tulson and other people within the team who have made and driven a particular key focus on that target, as well as developing a phenomenal tool which makes it much easier for me to visually see which staff have had how many audits at what time. It's absolutely key, so some great work being done.
Great, that's really good to hear. I have a question about the charts, particularly on page 3. I just wanted to understand how those variables are presented. So it's the horizontal axis that I'm unclear about. So if you looked at one of those lines, doesn't really matter which one you look at, the blue lines on page 3 of 5. I'm in exec scorecard.
The exec scorecard.
Yeah, exec scorecard. The question is, how many data points? I mean, it looks like a continuous variable. Call volume, for example. But we're actually only looking at 3 data points.
I think you're looking at the 0845 one.
I am looking at 0845, sorry. I am. So we are actually only looking at 3 data points. I think if that's what we're doing, those charts need to show 3 data points rather than a small curve, because it's very misleading. It looks as though we've got data from every day and it's smooth. Do you see? It's just confusing. Because we don't know really whether it's smooth or not. Got no idea. You basically said
3 data points. It could be just random,
anything.
couldn't it?
Exactly. And it could be anything in between.
Yeah.
So let's avoid the possibility of misleading ourselves into thinking that really is a curve when actually it's 3 data points. Fine. And if we can apply that principle throughout, if there's only 3 data points, let's show that.
Yep.
Okay, any other questions on the performance package? So we've got the staffing capacity paper before the finance report.
Yeah.
How should we do that?
Shall I pick this up? I think in truth, as board members may surmise, this is probably more at an executive level than a board level.
Yes, I agree.
What it shows is the prospective forward staffing for call handlers or health advisors and for nurse advisors or clinical advisors for the next 6 weeks, and therefore includes the August bank holiday. And what it shows is by the hour, so for each hour of the day, whether we have sufficient staff, too many staff, or not enough staff. Green shows that we've got the right number of staff or more than we need, and you can see that our call handling prospective staffing looks very good, and certainly not a threat to service levels. Our clinician or nurse staffing going forward, particularly over the August bank holiday itself, we are challenged at certain hours of the day. So we are 22 nurses light on the bank holiday Monday of the 26th of August between 9 o'clock in the morning and 10 o'clock in the morning, which is when there is a traditional peak on a bank holiday. And as a result of that, what Chris notes in his report, but I suspect somewhat opaquely because it's mostly in jargon, the efforts that are being put in place to put that right, to deal with it. And I'm firmly of the view that you measure what you care about, and we care whether we've got the right number of staff on by the hour every day of the week, and we'll continue to focus on this. I suspect that we will keep this at the executive level, and we'll just simply report any exceptions to the board in future.
Yes, that's interesting. I agree with you. It looks like an executive level management tool more than a board reporting item. It does show 1 or 2 quite interesting things though, doesn't it? So you've picked up on the shortfalls, which are obviously the key things in relation to quality and safety, but it also shows up to 62, I think was the biggest number I saw, excess capacity in parts. So I mean, every number in the green above 0 represents cost without benefit.
Well, the benefit is that our service levels are not at risk.
No, but well, okay, so it's buffer, but presumably a very well managed organisation would expect to have single figures in terms of excess.
Single figures,
Possibly. I mean, we have refined our call off with Conduit, reducing it from over 10,000 hours a week down to 7,800, and we are in dialogue with them about the ensuring that we continue to have a safe margin, but potentially dialing down our call off below that.
And what do you consider a safe margin? Because I would have thought that green should be telling us that
So
it's a safe margin.
So the safe margin is by experience, because what we're doing here is projecting the actual staffing that we will have on, not what it says on paper we will have, because that's useless. If what happens is that you find that shrinkage is the jargon in the trade, that you find people who either don't turn up for their shift or are diverted for one reason or another. So it's actually having a regular experience of knowing at what level you roster in order to have the right level. So we will learn by experience as we refine and reduce the margins to make sure that we are not going below the level that is required, but yet not wasting money unnecessarily by having too many. And it's refining those margins week on week. So this is a weekly activity, and making sure that, so it's not just a question of numbers. When you reduce the conduit call off, one of the things that it does is it gets rid of people's hours in the times when you need them, as well as the times you don't need them, because it induces attrition. People decide that if they're only going to get 16 hours a week, they will leave rather than stay. And it may be that you didn't want the 10 or 15 or 20 hours over their 16 because it was in the wrong time of the week, but you do want their 16 hours because it's on a Saturday night. And therefore we need to be careful that in reducing down the volume of the call-off, we don't inadvertently end up having a problem because we've unplanned attrition. And that's the issue that we're keeping very closely on top of.
That's very helpful, thank you.
Ruth?
Nick, I just, given the media today and the dispatches programme this evening around understaffing, I think that we just need to reassure the public or commissioners who may be watching that this will look more green.
Well, yes, absolutely. So at no stage, so we have a virtual national network for our nurses. So at no stage are our call handlers without clinical advice available, that either from clinical advisors or from the CQI leads who are also rostered on duty over and above these numbers. So secondly, we're currently achieving about 85% of calls that require access to a nurse are warm transferred. And as you can see from the previous report that we were discussing, our callback for those patients, a small minority of patients who need warm transfer but have to have a callback, that the vast majority of those are receiving a callback within 10 minutes. And we're certainly at or above the levels that are being achieved by other providers.
It's very good to see that this is the kind of tool you use to project your forward staffing, so you're very clear where we have small shortfalls, and they are small, that you're able to anticipate them and react to them. So that's very helpful. I would go back to, if it's green, presumably it means that's got the right amount of buffer in it. So green means green is good, and anything above 0 in green looks like a lot. I would also just observe that I think it's interesting that the point you raised about conduit staff, that if you reduce the number of hours, people might leave. I mean, I'm sure that's true.
It does happen. It's not might. That we know that happens.
I would suggest it's also true that if you're sitting around not being fully utilised, that's not a fulfilling job. So being underutilised probably also has an impact on whether people find it a
That's not been
job.
our experience.
So
People are very happy to turn up for the salary. Thank you very much.
Interesting. It's a shame.
It's life.
Okay. So we've agreed that this is useful but not
And
going to be
undermining
something.
your narrative on it. Thank you.
Excellent.
We have a grip on it, is what we're trying to demonstrate.
Yeah, that's great.
Okay.
Jackie, would you like to introduce the financial numbers for the month?
So in terms of the financial report for the month, we have got a year-to-date deficit of £4.3 million, which is 82,000 slightly adverse from our revised plan. There are sort of three areas where I would just like to highlight particular risks. The first is on 111 income, and I think I've mentioned them as risks in the paper. We are expecting within our plan about £5.4 million of income from 111 services for Q1. We've only received 1.3 million in actual cash payments so far, and we don't have any real indication that they're willing to pay the rest at the moment. I would suggest that currently commissioners are only wishing to pay about 3.2 million of the 5.4 million that we're proposing, giving us a £2 million real risk. We've escalated that to NHS England because in our view the reason why we believe we should be getting 5.4 million is because they are requesting us to carry on to deliver the current levels of 111 volumes.
Absolutely right.
And we're unable to reduce any of our fixed costs as a result of that.
Absolutely
because
right.
we still need to provide other services for the 5 sites, etc. So we will be continuing to pursue that one, and it has now been escalated. The second area is
Can
on.
we just ask about that one? Because I do think that is, I did raise it with you before.
Yeah.
So it's being escalated. I just wanted to check out what resolution we feel we can come to on this, because it is a major problem for us looking forward if this isn't resolved soon, because even if you look at it, the incident issue, if you like, in April, where the contract did go out of line, it's 4 months now since then. We've had constant dialogue, and I appreciate the amount of high-level dialogue you've had, but we're being ignored, in my view, on this one. And the longer it goes on, the more difficult it becomes for us to maintain our financial profile.
Okay. So the board will be aware and will be, I'm sure, satisfied with my confirmation that we continue to be focused on the resources that are necessary to provide the service to our patients, irrespective of the income machinations that we have with either local commissioners or anyone else.
Yeah, so just to be absolutely clear, we are separating the two issues. We're going to be talking about now, we're going to be talking about the things that we need to carry on doing to assure ourselves of the income. That's a separate discussion from are we staffing up to provide a safe service.
I wanted to make sure that anybody who wasn't as familiar with the context as the board is that the discussions we're having around income are somewhat irrelevant to the actions that we're taking to safeguard the services that we're delivering to patients. The reality is that NHS commissioners pay NHS providers money, and it goes round in a circle. There is only one vote of Parliament for money for the NHS, and in the end it's a net zero sum between commissioners and providers. So what we're talking about to some extent is what numbers are written down on a piece of paper to present who paid what to whom. But the real economy, if you like, is about how many health advisors and nurses that we have to answer calls for patients. I have escalated our concerns, which I know are shared by Paul Watson at NHS England, that we, first of all, do not let these discussions, these arguments get in the way of providing a safe service for patients. Completely agreed. And that secondly, once it has been agreed what the future of our 111 services are going to be, that there is a resolution to this issue, and that there is clarity and certainty for all parties concerned about what financial transactions are going to support us for the remainder of the year. So I think commissioners have concentrated on reaching clear agreements about the real actions, the real things that matter, and have left the income side to one side. And it's a frustration to us. However, we are backed by the Trust Development Authority and by the Department of Health, because of course the reason, because we've only been paid 1.3 million out of 5.4 million, we actually have more cash going out of the door than we have coming in. And they recognise that firstly they will continue to provide us with cash, but secondly they have an incentive to ensure that agreement is reached with commissioners to actually balance this off. And that's not been ignored by the TDA, and I know it's been raised by them on our behalf to NHS England. So there's a lot of words
So
there.
you don't
but
think it'll be resolved until we have finished the contractual
I think that's right.
handover arrangements?
I think local commissioners and NHS England will not reach agreement with us until they know what it is they're going to be paying alternative providers to take on the service, and I suspect that we will be the balancing item, but which is slightly horrifying to us.
I think
we
it's
have very little leverage.
Yeah, I think it's important to note that I did do a formal report on what we were expecting to receive for the first quarter, so that is fully documented.
Yes.
Why we're expecting to receive 5.4 million and
Exactly.
who from.
Yes.
And that will
But I mean,
be
commissioners can't have it both
No.
ways. They can't expect us to maintain our fixed infrastructure until such time as gradual transfers can take place, and yet not recognise that financially.
I'm just doing some mental arithmetic. So we've got unpaid invoices of £3.1 million right now. We've been running this service for 3 months. It's going to take another 6 months to sort out all these commissioners. So we're talking about 10 million.
Yeah.
Isn't it 4.4?
I'm sorry. So we're talking
5.4 minus 1.
we're talking 12 million potentially
by the end of the year.
by the end of the calendar year.
So we're clear where we are. You understand the scale of the deficits that are going to be created. Where our cash position is being carefully monitored. We've got the TDA standing behind us, and somewhere in the system, the additional cost of providing 111 over and above what was budgeted will have to be covered.
Correct.
And it might appear as a deficit in our books. It might appear somewhere else.
Yes.
So, and that's what you were talking about, Nick. It's
Yes.
There's a real shortfall, and then the question of where that appears is essentially an accounting issue. And what's clear from our point of view is our priority is maintaining the quality and safety of the service that we're providing, and maintaining pressure and dialogue around the transfer of those services safely and effectively to other providers, and then thirdly, to resolve the financial accounting issues, and to do the best we can around the responsibility that we have as directors of this company to minimise the deficit that we're going to carry. So I think the situation's clear. Nick, as you said, we have relatively limited leverage. What Jackie's reminding us, which is very important and valuable, is being absolutely clear that we document what's happening, that we maintain a clear view, and that we continue in dialogue. So thank you for that. I think there's a limit to how far this conversation can go. You'll want to come back and tell us how we're getting on with that month by month.
Thank you.
So for the time being, I'm going to continue to assume that we are going to receive the income that we were planning to get.
Absolutely. Okay, good.
So the second area was on frontline staffing for delivery of 111. We have got an overspend of about £600,000 just for June. Some of that we will be challenging because it is with our agency and in-source partners. We're assuming worst case at the moment. And some of it is down to the previous report that we looked at, where we had the green numbers, which are more than single figures.
And just to revisit that for a second, I think we all appreciate that with the history being what it is, we are erring on the side of caution to make sure that we have the capacity to deliver a safe service. Against that background, we're doing what we can to make sure that we're not overspending and that we're not over-resourced. So again, that's clear. And as a board, we want you to make that judgment as you are, as you're able to do, putting safety first, but absolutely minimising the amount of unnecessary expenditure.
Absolutely.
Okay. And that's all I want to say.
Thank you, Jackie. That's great. Any more questions on the financial situation on the accounts? Good. All right. Thanks very much, Jackie. We don't have any items under the strategic section of the agenda, so we can go into governance and compliance, where we go to Alan on the board assurance framework and the risk register.
Thank you very much, Chairman. So the updated board assurance framework is shown at agenda item 8. Just a few comments, if I may. Since this report was prepared. I've met with the internal auditors because the board may recall that they made 1 or 2 comments about the format of the BAF at their last review. They are content that the recommendations they made are reflected in this BAF, and they're happy with its content and its structure. They are actually in the course now of planning an audit review in accordance with the audit programme for this year, and are probably going to do most of the work at the earlier part of the financial year in order to strengthen the evidence available to them for their year-end head of audit opinion, which clearly was an issue for the organisation last year. So I was quite reassured by that. The version of the BAF now before the board, as I mentioned at the last board meeting, has now picked up the risks associated with delivery of the objectives in the business plan that was approved, the revised business plan approved at the early part of this month. So many of the risks are shown as new because they are added to this version for the first time since approval of the plan. And those items that were on the corporate risk register that was shown at the last meeting have been accommodated in here as well. We are now setting off on a process of training events for directorate staff as far as maintenance of their individual directorate risk registers are concerned, so that at the next board meeting in September we're able to bring hopefully a consistent and an updated corporate risk register to complement the BAF, and we will then be carrying out a monthly review to make sure that risks are added as required, deleted when they've been seen off, although I think most of these are likely to see us through the whole of the financial year because of their association with business plan objectives. And I'm reasonably content that the strengthening of the risk management function that I think was necessary is underway.
Alan, thank you. I've got a couple of questions. I just wanted to understand, so this is based upon the business plan, which was by its nature provisional, given the uncertainties about what was going to happen. So now we're in a position, having made the announcement that we've done in our annual report and your statement earlier, Nick, about the future of our 111 services, to, I guess, see that the biggest risks are transfer and how we do that, and the associated financial aspects. Shouldn't those be the sort of now the headline items in the risk register?
I think they are starting to emerge. So we're developing our transfer plans. We've got a programme in place to do that. Part of the work, the initial work, is to identify the risks associated with that. You can expect to see some adjustment either to this or to the risk register at some point in the future as we start to scope those risks.
I mean, I'm confident you can do that. I guess sort of intuitively it feels as though there's our, you know, if we ask, the litmus test of the risk register, I think, is often you say to the chief executive, well, what's keeping you awake at night? And what always keeps us awake is the quality and safety of our services. But in relation to now, it's about safe handover and how the money's going to.
Yeah, so it's the bureaucracy of it. That's all.
So just to be really clear, of course, what we announced earlier on, or what we made clear in the public domain, was that we are seeking to withdraw from 111 services. That has not yet been agreed. Alternative providers have not yet been appointed by commissioners, and we don't know what the timing of that will be.
So isn't that the risk? So,
well, our current plan is that we will continue to deliver the 111 services for the remainder of the period covered by the business plan, which is up until the end of March 2014. And we will formally come back to the board with a revision to that business plan as and when transfers are agreed. But as we speak today, it is entirely possible that some or all of our 111 commissioners will seek for us to continue to provide the 111 service for the remainder of the calendar or indeed financial year. financial year, so that our current business plan will continue this year. That's entirely feasible.
And that's at the moment how the BAF reflects the position, as if the business plan to continue delivering until March is seen through, and this will need to be amended if and when firm plans are agreed and signed off.
And it's a very important distinction, actually. Yes. So were Chris here, he would be able to show you the imprint of my words upon him, that for the avoidance of doubt, we are running these services until relieved. And that means that we do all of the things to prepare for winter, and all of the things that we would be planning to get organised to deliver for the remainder of the year, we need to do.
That's fair.
And get paid for it.
Hopefully get paid for it. At least invoices, that we can guarantee.
We can invoice it. That's fair.
Yeah, I don't want to beat this one to death, but I would like to have a further conversation about how we express the fact that we are planning to be sure that we can maintain a safe service until handover, and the risk that we don't find an appropriate handover solution. But
yeah, I understand.
There's no point in doing it here.
It might be appropriate to have a short discussion in the private part.
It might well be. Okay, fine. Thank you for clarifying that.
I tried to clarify.
Yeah.
Have or not, remains to be seen.
Are there any other questions, comments, observations on the risk register or the board assurance framework at this point? Okay. Then let's go into some minutes and some feedback. So, Peter, you've got some minutes here that you've already fed back to us.
Last time.
Yeah. So on your behalf, can I just ask anyone if there are any comments or questions on the minutes? Okay. Ditto, I think, on the Finance Committee, Tim.
Yes, I gave a verbal update to the last board.
Are there any questions to Tim or his colleagues about the minutes for that particular meeting? No? And then now we've got a new meeting which has taken place since we last met, and Tim, you've kindly volunteered to provide some feedback on it. We've got the agenda, which is sort of your aid memoir and a prompt for us if in case you want to ask anything about it.
To the Clinical Governance Committee meeting on the 12th of July, there were 3 or 4 things which came out of that which I'd like to draw to the attention of the board. The first, that bearing in mind modest problems with performance, which in fact the latest performance report suggests are solved in terms of accessibility and callback solved or at least improved. We had a discussion about how we prioritise whom we call back, much akin to how we used to do it with 0845 with P1s, P2s, P3s. This is something which we're obviously very keen on in terms of clinical safety, Clinical Governance Committee, and is something which I know we've asked that further thought is given to by the Executive and propositions returned, accepting that already we are mapping the DX outcome codes in pathways to a pseudo-prioritisation, which is done automatically and gives our nursing staff some guide as to which calls need to be called back first in times of affluence and in terms of times of busyness. So that's point number 1. We discussed, as we always do, statutory and mandatory training, perennial topic of interest, acknowledging again, as has been discussed earlier today, that we're making good progress, and part of the apparent deficit is to do with data cleansing. It perhaps needs some further discussion more generally as to how the leadership on that is taken. If once data is cleansed, there is still a problem with statutory and mandatory training. We are keen to draw the attention of the board to the need for greater involvement, particularly of the non-executives, my non-executive colleagues, in peer review, in keeping with France's requirements to have us close to the action, in that I think our attendance in peer review could have been better. I think it was the conclusion of the Clinical Governance Committee meeting. And so there are plenty of opportunities each month for us to share in those discussions.
Which we can do by phone.
We can do by phone, absolutely. They are by phone, yes, by definition. Although we perhaps also draw the attention of colleagues to the fact that you can sign up for and then discover the particular peer review is cancelled because it has been resolved and therefore is not required. And the final thing on the same topic really was that we were presented with a paper on learning from such reviews and how that learning is disseminated through the organisation. An excellent paper picking up various themes of problem, the standard themes of communication and use of systems, content of pathways and so on. A paper which the committee commended. It was excellent. So I think were the highlights from the governance.
Thanks very much, Tim. I want to pick up a couple of things on that. So first of all, this peer review question. Sorry, Alan, I'll come back to you in a second. So peer reviewers are. So I don't think I'd really clock this. So the Francis report has highlighted the need for non-executives to be close to those sorts of issues. We, as non-executives, get notified of the schedule for peer reviews. Those are by teleconference. It ought to be possible for us all to attend those from time to time. So I'm going to ask people to make a particular effort to, perhaps by the end of September, to have attended a peer review by phone, recognising, as you say, Tim, that occasionally they might get cancelled because they're resolved. But should we all try and do that? I mean, they're always an interesting and instructive exercise, and I think the Hawthorne effect of having a non-executive present is minimised by the fact that we're on the phone, so we're sort of I mean, people know we're there, but quickly become invisible. So let's try and do that. And then in relation to statutory and mandatory training and the non-executive involvement in that, I'd like to just have a bit of clarification on that. It may not be quite right now. We might do that under any other business, Tricia, because I must admit I think I have become a little bit confused as to what extent non-executives are covered by the, or to which statutory and mandatory training is applicable to non-executives and how we should participate. Is it a good moment to talk about that now? Or
yes.
Yeah.
Yeah. So I have a briefing note if board members would like to receive that, which states, I believe, my position and possibly some of the executives' position on statutory and mandatory training. For non-execs particularly, I think it's key that they participate in information governance, both aspects of safeguarding training, both for children and for adults, and fire training, particularly for this building of which you are frequent visitors. They would be the 4 key areas of statutory and mandatory training. I believe it's appropriate for non-executives to participate, and of course the executives around the table. We would request to complete all of the statutory and mandatory training that is equal to other employees within the organisation.
Okay, so that leaves the non-executives with 4, and we're not. And so there's been a slight issue, I think, of data in relation to non-executives because some of the non-executives done it on paper. So putting that to one side, is that presumably there's still a deficit in relation to the non-executives.
There is.
Okay,
there is.
which we must try and.
Yes, please.
So is it possible to provide to the non-executives a list or a summary or a statement of what they need to complete?
Yes.
Could you do that individually?
I will do that individually.
Perfect. Okay, just so that we can all be clear, because the years come round very fast for some of us, and knowing what we've done this year as opposed to last year would be helpful. Thank you. That would be great. Alan, sorry, you were.
I just wanted to pick up on the statement Tim made around the DX code mapping to priorities. It seems like that if we're doing that for our 111 services, it seems like that's something which could very easily be a sort of national standard, and therefore it might be something appropriate to feed back into the NHS pathways group to suggest as a change request to the way the clinical content operates.
We actually, when we developed the prioritisation, we did have discussions with NHS Pathways, and we also shared our experiences and our development of the prioritisation with NHS England, and it is my understanding, Alan, that some of the other NHS 111 providers are also using the tool that we developed.
Good.
We did share the clinical prioritisation process criteria and operating manual with NHS England, because I understand it is their intention to introduce some form of clinical prioritisation into Form 1 generally.
And of course what we know is that the background being this wasn't part of the original specification because everything was warm transferred, and in practice that hasn't been possible, and so there was a gap where prioritisation was important. Okay, that's fine, thank you for that, it's helpful. I think then we've done our governance section. Are there any other governance related issues anyone wants to raise? No, thank you very much, Tim, for your feedback on behalf of Sue. Let's then move on to stakeholder activity. Tim again, you've been to Dudley, I gather.
I have, yes. I had a day out in Dudley, as one does, and had an opportunity to talk to the deputy site manager. That may not be the right term, and some call handlers and clinical staff, and was impressed by what I saw and the enthusiasm, and taken with an observation that I heard several times, which is that over the last few weeks the organisation has really got a grip on how to deliver 111. And from what I saw, they certainly seemed to know how to do it, and I saw some very good practice, including, for instance, the auto-dispatch of a 999 ambulance, which is wonderful. I was again frustrated by the usual pathways, activities of going through the safety questions mechanically, time and time again, which could be done on the messaging. We've talked about that before. And heard of interesting views, individual views, which I think probably have no place in the public arena, but views about how transitioning to new organisation delivering the service might affect individuals, and how they view that, and how they view potential further organisations. Impressed though by the feel that I don't think people are going to be walking, given that there is a degree of certainty about long-term employability now.
Yeah.
There seems to be, and that was the feel I took away from my discussions. Further comments on core review and the awareness that this is happening, and ideas on how it could perhaps be made more useful.
You're passing those on, I imagine.
Indeed, I've had these discussions.
Yeah.
And one or two other minor surprises about how Pathways works, which again I've discussed with on an individual basis.
Thanks very much. It's good. It's great. Let's move on then, with sort of that in mind, to talk about our call recording, which we've all, I hope, had an opportunity to listen to. Not everyone. Anyone else who hasn't managed, other than Steve, who hasn't managed to listen to the call? Okay. Is that those technical problems, or?
No, mine was a time problem this one, sorry.
Okay. All right, so Tricia, would you like to just introduce it and we can have a conversation around that particular call?
Yeah. So apologies, Chair, there was only one call available for this month due to, we had one or two set aside, and we didn't manage to receive consent from the individual patients, so we've only presented the one where we did gain patient consent. This was a call that was made to the West Midlands 111 service in June, and it is related to a individual who rang the service having had some symptoms, eye symptoms, for a number of days. She had visited her GP and been given some treatment for that, but her problems continued, and her view was getting worse, and she felt very clearly that she needed to access some further face-to-face. The original inquiry was, did she need an appointment to the walk-in centre? And I think we've discussed at board on a number of occasions that do we really get to the nub of the patient's question before we actually onwards and continue to assess the patient. I think this is another example of the patient had a very specific request of, do I need to make an appointment to attend a walk-in centre? Very simple answer, no. you can just walk in. But we undertook a lengthy assessment where we actually concluded with advising this patient it would be appropriate to attend the A&E department, though the individual didn't feel she was safe to drive, and she didn't feel that she would be able to make her way to the A&E department. And we ended up concluding the assessment with agreeing with her where the local walking centre was. She didn't need an appointment and she could go. It is interesting, however, that on attendance to the walking centre they did not have the equipment to undertake the assessment that was required, so the initial disposition of A&E was the right and appropriate one, because it was guaranteed that's where the equipment, what's called a slit lamp, for you to be able to assess the state of a patient's cornea, would be there, available, with staff trained and able to use it. So it was an interesting review. And also you can see the CQI have passed comments on the calls, the nurse's assessment of the patient, highlighting the length of the call was excessive and unnecessary, and also giving some guidance on how that might be improved upon. And beyond that, Chair, I'll take comments and questions.
Thank you, Tricia. It is an interesting one, isn't it? So what would an ideal call of that nature be? So hypothesis, an ideal call would be, how can we help you? I want to know whether I need an appointment for a walk-in centre. No, you don't. Would you like us to do an assessment to make sure that the walk-in centre is the right place for you? Yes or no? If yes, then it would have led to A&E, an ideal call would have then ended up with, you might need your eye looked at with some equipment that might not be available at the walk-in centre. So it's really quite different from a 111. As soon as we've got you on the phone, we need to do a clinical assessment, because that's what our process tells us we've got to do. Mm-hmm. And then we'll negotiate the outcome with you if you don't feel it's the outcome that works for you. Mm-hmm. Very interesting.
It certainly does feel a bit daft when we're asking someone if they've had a stroke in the last 24 hours, 7 days. I mean, it just, and then, at least the clinic clinician said, I know you're breathing, so I won't ask you about that. I thought, wow, okay. Well, that took that off the list. But they have to sort of excuse themselves, saying, I've got to ask you these questions. And it feels as though they're excusing themselves to go down that route as well.
It's the fundamental going in assumption that 111's been built on, that every caller has got symptoms, needs a symptomatic assessment. And it comes back to what Nick was saying right at the beginning when he talked about the difference between 0845 and 111. That at the moment there seems to be a gap on health information of various sorts, because 111 is predicated around an urgent symptomatic need, and the whole service is built around that, and that is very important. But there's a whole range of needs outside of that, which 111 is an expensive, time-consuming, inefficient and not very good experience. Okay. Joanne's your personal view there. Thank you. I mean, it was interesting. In a way, there's not, you've summed up. We're all probably agreeing with you. Thank you for that. I really think it's still worthwhile. Let's have some more calls to listen to month on month. Let's try and get to listen to them. Thanks a lot for doing that. Okay.
Joanne, could I just make a point? In the interest of promoting our non-111 services, I will be doing some site visits over the next couple of weeks, so I'll share these dates with non-executives if anyone would like to join me. And it would be helpful if we could listen to some other services.
Yes, let's. I mean, for example, can we have some Care Connect calls? Since we were talking about that earlier, and that would be good. Absolutely. We want a range of different things. Yeah. Very good. All right. Well, I think that we have reached more or less the end of our public meeting. Is there any other business that anyone wants to discuss in the public meeting? No? In that case, we'll be meeting again on the 30th of September in public. As a board, it is possible, depending upon what happens about negotiations with other providers, that we may need to meet formally before then, and we've been canvassing for dates
either
around
the 9th
then.
or the 16th, I don't know which is
It looks like the 9th of September. And so we're going to reserve that date, and we may have a public board meeting in that slot, or we may not, depending on whether we need one. I suggest we have a 5-minute break now, a bit more than that, and we come back in public at a quarter. Private. At 1:45. Can we get some lunch in the